Status Dramaticus.
This is week 2. Last week we talked about the admission. This week we're going to talk about the diagnosis.
Status Dramaticus
This is a podcast where we pull back the curtain on inpatient care nursing. Here we take a holistic approach to describing the shit show that is nursing. In today's episode, we're going to get into what we're calling corporate medicine, and then we're going to talk about how patients are becoming commodities and not seen as humans anymore by these large corporate conglomerates. Today, we're joined again with Lydia. Go ahead and say hi, Lydia.
How you doing?
So our first section, our first topic today is what we're describing as corporate medicine. Some of you might be wondering what corporate medicine is, or am I working in it? Here on the show, we call corporate medicine these large healthcare systems that many nurses work in within these hospital systems. These hospitals used to be standalone kind of entities, community hospitals. But as things have progressed, in order to gain more efficiencies, and in order to bring down what we thought would be the cost of healthcare, these hospitals that were once community run by small doctors and nursing boards have joined together to form large conglomerations. So let's get into the crux of the problem. You guys are nurses, you work in hospitals. On this show, we're using this term that we describe as corporate medicine. Some of the newer nurses may have only known this corporate medicine structure, but working with veteran nurses that have been nurses at the bedside for 30 years, they're used to a different model. And that model was the community-based hospital, a small entity that was managing themselves in the past. However, as things have gone forward and healthcare costs have exploded in America, we tried to apply capitalism to this model. That's when these small community-based hospitals started to join forces in order to get better pricing, better efficiencies, et cetera, et cetera. However, we're now seeing the end results of this. And the end result of that is what I call, and what we're calling here, corporate medicine, and the culture that comes with that. A corporation, by definition, has to put its shareholders first, which means putting their shareholders first, they have to be concerned about revenue and the bottom line. And you might say, whoa, Jason, hey, but my hospital is different. We're not profit. We're not for profit. All that really means is they have to spend all the money by the end of the year. It's still a corporate structure. And what you've probably seen time and time again is by spending the money by the end of the year so they don't show a profit, they give themselves bonuses, or they build some new giant healthcare cathedral. All the while, the nurses, the CNAs who are doing the work of caring for the patients, why we're all here, are getting paid exploitative salaries. They are getting beat up. They are getting not cared for. And then, if someone has the gall or audacity to speak up about the working conditions, guess what? That nurse is the problem. And they usually get fired. And this is a product of corporate medicine. The power structures in place, instead of dealing with the corporate culture, will label that nurse who's speaking up and saying, hey, what's going on here? They will get rid of them in order to protect that existing culture. What healthcare needs to be is something that is not based on revenue, which means we have to go to a new model that doesn't put revenue first, it puts patients first, right? So hopefully by identifying and naming and diagnosing what this problem is, which is corporate medicine and the culture it produces, we as nurses can start to get our heads around about how we're going to fix this problem, how we're going to tackle this problem, and how we engage in these workplaces when we go in to protect ourselves, our patients, our coworkers, and our mental health, most importantly. Things are bad right now. You know, we're in a pandemic, we're in another surge, but here's the crazy thing. Why things are really bleak, when any system is in crisis, that is the best time to adopt change. And that's when change happens the fastest, is when someone or something or an organization is in crisis. So now is the time.
Jason, like those are a lot of good points. I feel like a lot of people don't understand that about what not-for-profit means. And that's a really good way to sum it up is that, they don't show profit, but they can give it to their CEOs or whatever's left over on the budget at the end of the year. To be clear for our readers, listeners, and viewers, when we say corporate, we mean, everybody from management all the way up to the top administrators. So if we say, oh man, fucking corporate, we're talking about management, administrators, everybody who's not at the bedside and not providing care. Because to be clear, while they want us to be educated, right? Like a lot of hospitals go for magnet status and they want all of their nurses to have at least a bachelor's degree. And I'll share this. I don't have a bachelor's. I'll never go back for my bachelor's. I have my associates. I think, Jason, you do too. You have your
I have an
associate.
associate, and I see no point in getting a bachelor's. It's like, unless I want to be a manager and go and join this corporate culture, right? Like,
Well,
I want to be a bedside nurse. That's it. I don't need a 4-year degree to do that.
And a fun fact is that 43% of hospital administrators have a bachelor's degree or less. A small percentage only have a high school diploma. Yet the national average for hospital administration is $381,000 a year. Okay. And you have to understand there's people that are making a lot more than that who are obviously outside of the bell curve. And to do that with less than a bachelor's while they require it of us, pretty unfair.
What sense does that make, Lydia? And these administrators and stuff, I don't think they're bad people or evil people. And like, I'm sure the people that are listening to this, they're on the units, and we tend to paint these people as like these villains, right? Because it's like a lack of communication. But what I never understood and what I've seen throughout my career is a nurse will then step over the line from bedside to management, and then all of a sudden they're saying different things, they're a different person. So it is the pressure that is being exerted upon them from this corporate culture that is forcing them to toe the line or adapt. So they stop forgetting about what is happening at the bedside, what it was like to be a bedside nurse. It's almost like they're indoctrinated and they have amnesia. In my very first job that I ever had, one of the best managers I've worked with, and she was like, she had our backs. She was a nurse's nurse and like a manager that would stick up for us. And it was where we first started, Lydia. And one day, I guess she said the wrong thing. She was walked out. The staff was never told why, what happened, anything like that. I saw her years later at an ACLS training, and she was not towing that corporate line, and she was kind of too much of a nursing manager, not getting us into line. So it's just another example of this like groupthink in this corporate healthcare mindset that is not allowing for true reflection of what the problems is. So we keep doing more of the same, and we keep getting the same results, and healthcare costs are going through the roof, and it's gonna bankrupt the nation. So this problem we're talking about really concerns every American. Like, we all need healthcare, we're all paying taxes, and we're getting shitty outcomes for the amount of money that we're paying. So what's going on here?
100%, 100%. And, it's also showing with this pandemic, which has really put us in crisis mode even further, literally, because there are so many people just straight up leaving healthcare. Now, since the beginning of the pandemic, and they're marking that, I think, as like February of 2020 for the United States, because that's when they're counting the United States pandemic to have started. Since February of 2020 to November of 2021, 18% of healthcare workers have left, completely left. And when they talk to critical care nurses, another 66%, that's 2/3, to be clear, are talking about leaving healthcare altogether. Now, 66% are considering it. If even 20% of that leaves, we're screwed as a nation, as a country. Idaho is already in and has been in crisis standards of care for since September, which means every adult who comes into the ER is an automatic do not resuscitate because they're out of ventilators, they're out of fentanyl, they're out of propofol, they're out of the things needed to have a code. So they have to save those supplies for pediatric codes. So we are definitely at a catalyst. And now we need to start talking about how we can change it and what the problems are.
And what is infuriating is I haven't seen a word from administrators about correcting the issues that we're facing. COVID is a stressor to the system. We as nurses, the ones that are left on the health, on the floor, working in the hospitals, we can handle that. The true crisis is staffing, and we're not changing our models. We're sticking to these same ratios, and these corporations, they're pretending like everything, just waiting for things to go back to normal. We're still having these JCO inspections. You're trying to hold us to the same standards that we were practicing at when we had staff and we didn't have a freaking pandemic going on. So it's like, wake up.
It's because they're talking to the wrong people, right? They need to wake up and start talking to the right people to make a change. It's not going to come from administrators because they're so far removed. We need to start talking to the right people. Who do you think that is, Jason?
It makes sense, right? The right people, whenever you're facing a problem, those people that have the solutions to the problem are the ones doing the work. So that means it's the nurses at the bedside. It's our aides. It's the people on the floor delivering healthcare. For some reason, this model now has gotten to where we disregard, or in my opinion, people look down on a bedside nurse as if, that's all you do. You're just a bedside nurse. Like, for some reason, there's an idea that we've been trained in our school to continue on. But if we stop and think about the amount of skills to be a proficient, professional bedside nurse and traveler, the amount of skills that go into that is incredible. It's applied sciences, knowing what's going on, how to react to an emergency situation. We are highly, highly trained medical professionals. And that all that knowledge is disregarded to me, in my opinion. And when you try to say this is the problem to your manager, we're being disregarded. And I think it may go to a little bit of us speaking different languages. The people leading us are people that have MBAs, they're CEOs. They speak corporate jargon.
Maybe they don't.
Yeah, maybe they don't.
Maybe they have a high school degree and they're just making, 4 times whatever we are because we're just the dumb bedside nurses.
Exactly. But I think that disconnect of why we're not getting the answers from the ground up to the bottom up is you have a couple problems going on here. You have people making policy of what good healthcare is that don't understand what's going on the bedside, what best practices is, and that comes from a lack of lobbyists for nurses and doctors. We don't have a healthcare lobby. The biggest healthcare lobbying is what they call the Hospital Association, and it speaks for 5,000 American hospitals. I just looked this up the other day. They donated $15 million to politicians. So in American politics, yeah, we get to vote. It helps a little bit, but we all know the true rules of the game currently in our politics. Money talks, right? How do we get people to change policies? Lobbying. So you look at the biggest one, hospital associations. They're not talking for nurses and doctors. They're not talking for people that are doing the work. They're talking for corporate medicine, and corporate medicine doesn't understand the problem currently because they're not listening to the nurses at the bedside. So thinking about maybe why that is, I started a small startup about 5 years ago, did some business training, incubation training. So I understand a little bit now of what we call business talk or corporate jargon. Even if you have a high school education or you're a nurse, once you step over that line and you go into administration and corporate medicine, you start learning this jargon. If a nurse talks to a CEO or a director of nursing who's been doing that a while, they've been so far removed from the bedside, they don't remember medical jargon. So when a nurse is talking medical jargon to someone who speaks corporate jargon, we're both speaking English, but those are two different languages that don't go together. So there is a huge disconnect going on. And finally, with the wrong policies in place that tell these hospitals of how they're going to get paid, it puts pressure for the corporate structure to create policies from the top down of what needs to be happening at the bedside for revenue to be generated. It's not congruent. It's out of whack. That's why capitalism can't go with healthcare. Competition will not bring down prices in healthcare. Efficiencies aren't working. Healthcare costs keep going up and up and up. And we keep blaming it's insurance companies, it's the greedy hospitals, it's these dumb doctors who we never see on the floors anymore. You know, no offense to my doctor friends. In my opinion, I don't know how much longer in a hospital acute care setting, like in the ER, yes, you still need a doctor. In the ICUs, sure, you need an intensivist. But I'm sure many of our listeners, do you guys see, especially at night, do you see doctors going in these rooms anymore? They're looking at computers now and they're just mining data.
You know, and that's charting, right? Charting, that's a huge problem for nurses as well. You know, you can read these studies because they're the overwhelming consensus among nurses in all these studies is that charting takes away from the bedside. I read one study, and you know, maybe it was paid for by the hospital systems, but it said there's no conclusive data because half of the time an equal amount of time is spent between charting and spent between the patient. Well, how is that not conclusive? I'm not a statistician, but that right there says to me that half of my time is spent charting. That's pretty conclusive. That if I didn't have to chart as much so they could generate profits for every little box that I checked, then wouldn't I have more time with my patient?
Right. Isn't that kind of the idea, that we spend time with our patients? We're educating them on what's happening to them, what they need to do to manage their disease, what tests are ordered. But we're getting pressure
What they need to do to not come back to this hospital.
Right, right. But we're spending over half our time on charting, and more pressure gets put onto us on charting. And if we don't get our charting in, we're getting in trouble. We're getting called into the principal's office, and it's useless work. Newer nurses may realize this, but a lot of older nurses don't. So where I'm working now, they just went to a new EMR charting system. And during these like pandemic conditions,
Which one is it?
it's Cerner. It's not terrible, but you know, it's fairly
But
easy.
they got away from McKesson, which is
Paragon, which was
I know some of our listeners
like
have
Paragon.
used McKesson and like,
If anyone has used Paragon that's listening to this, or if you're still using it and you haven't used anything else, I apologize. I know you've adapted to it, but there's something better out there, and it'll be coming for you. I promise. Paragon is like looking at Windows 95 and these different boxes. I'm like, where's the dancing like paperclip going to appear? You know, it's so antiquated. When I walked into where I'm like my
that dancing paperclip would be fucking helpful compared to like the useless nothing that is Paragon.
Yeah, maybe you could point out a critical value in case I'm missing it. Like I literally had fear, and I only had to use it for 2 weeks, that I had no idea what was happening with my patient. Like I couldn't find these values. Like where, like
don't worry, because no one else can either. Doctors can't read your charting in Paragon. Don't worry about it. So don't worry.
Right. And you know, we think technology is solving so many of these problems. It's a double-edged sword. When there was that paper chart, that nurse-doctor relationship and communication, like people knew what was going on. Now with the advent of like Cerner and Epic, we've been like reduced to spreadsheets and like these long click button boxes to describe what's happening to our patients. Well, this didn't happen to me until, I don't know, 2 years ago, when I'm talking to him, like my best friend who's a doc, and he goes, yeah, Epic Cerner isn't made for patient care. It's made for billing and revenue to justify the orders to insurance companies that the hospitals don't, to justify the orders I'm putting in as a doc. So real quick, I'll lay out kind of like what happens when a patient comes in. A doctor comes in, they're reading the notes of other doctors, and then they may or may not go actually talk to the patient. Some do still, so that's impressive. But They're looking at the notes, the consultations, and then they are ordering tests to do a differential diagnosis on a patient to rule things out. And they order a bunch of tests because we live in a society that is so litigious at their point. They're CYA covering their own ass. Right there, that's ballooning healthcare costs. Then on top of that, nurses are charting away, charting, because we're told by our managers, administration, you got to chart. And in school, if you didn't chart it, you didn't do it. That never made sense to me. Like, I'm doing lots of stuff, so much stuff sometimes where I actually don't even have time to chart, but I have to stop doing stuff and delivering care to my patient so I can chart it so it looks like I did something so I don't get fired. Like, what the fuck? What the fuck? I want to be with my patient. I want to take care of them and be present. Computers create a huge
Jason,
barrier.
that's why you're an idiot, according to corporate. We don't deliver healthcare, we deliver charts.
And how many people out here know this nurse? It's care from the chair, but they're never in trouble with management because their charting is impeccable. But when you follow them, their patient is drowning in piss because they haven't seen them all night. Everyone knows that nurse, right? This
100%.
system allows for that. And, finally, like really looking into this, why it allows for this is our charting as nurses, why doctors don't look at it. They don't go through our flow sheets. If a nurse writes a note, they'll look at that to see what's going on, or talks to you in person, that will go into the patient's healthcare. Our charting doesn't go towards patient's healthcare. It goes towards billing. So these flow sheets.
Billing or court cases?
Yeah, court cases. But I mean, how many actual court cases are there where nurses are involved? They're not suing us, right? Maybe they pull it out there, but I don't care like if the doctor's getting sued. I don't want to waste my time protecting this doctor because he fucked up or whatever, It's this idea of moral injury where literally studies are showing I'm spending half of my 12-hour shift doing busy work to generate revenue. So if the revenue is actually being generated through charting, then these corporate medicines structures, their primary motivation is revenue. Revenue comes from these flow sheets, charting, and tests being ordered. The EMR, the holy EMR, is now taking primary concern in their eyes. It's no longer the actual patient. They're just a source of generating revenue that we can put in electronic orders and we can click boxes about. But these boxes that we're clicking and these orders that are being placed, that's what's making the money. That's why we're getting so much pressure to do all this Q2 hour checks, Q1 hours, Q2 turn hours, all this insane amount of charting that is almost impossible to do if you have. The other night I had 7 patients. If you have 7 patients, the amount of charting you can't do. So in order to get in trouble, okay, I know what my charting expectations are. Let me get some stuff in there. It's this kind of somewhat gray area of this fictitious charting that everyone kind of knows about it, but we're trying to do our best. But at the end of the day, it's this moral injury. I'm spending half of my time that's not leading to better outcomes for my patient.
I just was in on my most recent contract when they were orienting me to the charting system, which I already knew. So it's just they kind of could do a quick brush over. But literally, she said, if you make a mistake, here's how you correct it. This was in Cerner, and some of the things in Cerner, when you correct something, you have to enter a comment. She goes, you can just put clerical error. And I'm thinking, wait a minute. So now I'm a freaking clerk or a data entry clerk or something that I could put just clerical error on this? Are you serious?
Half of our job is now data entry, right?
I was at another contract and I was being oriented, and at the end of the shift, my preceptor goes, oh, you didn't enter this or this. And I was like, well, I didn't do those things. And he said this, he said, oh, they don't care if you do them. They just care that you charted them. This is what is actually being told.
Yep. This is how skewed it's gotten, where people are just saying, it's not actually important now if you've delivered that care. It's more important that it's been charted, because this is what justifies these orders that may have not been needed, but then these hospitals can get some sort of reimbursement for it. It's the revenue source, the holy revenue source. comes from the holy EMR. So now patient care is actually secondary. The whole reason why we're there, the people in the bed that need our help, have now become secondary to American healthcare because we need to just get stuff in the computer so we can bill. It's
this idea of patient commodity.
Right. So these patients are now just these little like biological like sources of EMR billing generation opportunities that are laying in the bed. So we now have like been pushed to view healthcare. It's a business. We all say it's a business, and we've all been indoctrinated by this. The takeover of healthcare by corporations and corporate medicine. Healthcare is not a fucking business. Our business.
Jason, you love Bitcoin. You don't want to mine Bitcoins out of humans because that's kind of what it is.
I don't want to mine human beings. I want to be present for them. I like many nurses, and I just kind of realized this, like our career is a career in suffering, in observation of pain. We go to work each day, Lydia, in the house of pain. We call it a hospital, right? And our computers and this click button stuff is a barrier. As a nurse, I need to be your healthcare Sherpa to tell you what's going on, to tell you that pain is okay. Pain is part of the human experience. Living a pain-free life that has been pushed on us by big pharma and that bullshit, that's outrageous. Whoever thought the fifth vital sign, like, you know, coming out of the other side of where I'm at in my career, going through nursing school, I remember pain is the fifth vital sign. Pain is subjective. Yes.
Which is crazy, right? Because here's the thing about vital signs. If any of them are 0, it means you're dead. If my heart rate is 0, I'm dead. If my respirations are 0, I'm dead. If my blood pressure is 0, I'm definitely dead. My temperature is 0, still dead. But get this, if I don't have any pain, as I'm sitting here right now and I say my pain is a 0, I am not dead. Therefore, it is not a vital sign. But we all know that the opioid epidemic pretty much started when pain was made a vital sign.
Right. And to our listeners, it's really hard to watch. It's a documentary, and there's a dramatization of it on Hulu called Dope Sick. The documentary is called The Crime of the Century, and it literally lays out the court cases, what is happening, how big pharma used marketing techniques, little brochures to convince country doctors who kind of, in my opinion, fell asleep at the wheel. They said, I know my patients are addicted, but this little dude that's got a bachelor's degree is showing me this, you know, kind of okay study about this, and this. Well, it's pseudo addiction. Or if your patient's in pain, they need more pain meds. Keep titrating up. At one point, Purdue Pharma produced a Norco pill that was 180 milligrams. What?
Oh, those were OxyContin pills, and I actually I was working in a nursing home at the time, and I wasn't a critical care nurse yet. I hadn't entered acute care, and this patient was probably needed some Narcan. Like I had to shake her awake, and I did not give her her next scheduled dose, and yeah, it's just crazy to me, but I actually remember those pills. And Jason, have you ever had a patient on a Narcan drip? I don't know if you would in step down,
maybe
but
like once.
Maybe you've seen them when you've been floated to ER.
Yeah.
But it's almost it's sad, but it's also, gosh, it's crazy that I've had a patient who begged me to shut off the Narcan drip so she could be high, even though if I had, she would have stopped breathing.
Right. And so, like, what we're starting to learn too is pain is created, right? We have this idea through corporate medicine takeover, just prescribe more, titrate up, give more and more. Big pharma's making more and more money. People are pain-free. Pain is a constant in the human condition. Even though, like you and I sit here right now, we're like, you know, I'm not in any pain. There's processes that are happening in my body that would probably I would be in pain if I was paying attention to them. But I've learned to just kind of ignore them and be in this like kind of like maybe one or two, what I would say good and pain-free. But there's pain processes happening all the time in our lives, right? Cells are dying, blah, 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 blah. So going to a zero of pain-free is a product of corporations. And now we're coming to the other side of this. And
To numb us all from the pain of the world.
right. And so we know, like, just basic like physiology, the more you give of a substance, your body will adapt. It will upregulate. You give more, you titrate up on the pain meds, more pain receptor sites are created so that patient can take more pain meds. And then suddenly they're still in pain, so they need more. And it's not that these patients are faking. These patients are having real pain. I'm sure, they get addicted, they enjoy the escapism, addiction and stuff. That's neither good nor bad. Every human is capable of getting addicted. In society, we say, if it's drugs or alcohol, that's bad. But, people are addicted to pornography, food, coffee, whatever, but those are good addictions. And now on the other side of this big pharma thing, we have all of these addicts that now have been cut off from their pain meds. It's been titrated down, but they still have a huge addiction problem now. They still
And
have
we're left
actual
with
pain.
individuals at the pain clinics and the pain plans and stuff, and they don't
Right.
understand why they can't just get high anymore.
Right. Or they're actually, having pain. I just saw the idea. So, it's this idea of myelinating these neural pathways, the hypersensitivity of the central nervous system. So they showed in a study, a person with chronic pain that is on a huge amount of pain meds, to prove this idea of the hypersensitivity of the central nervous system that they think rolls into fibromyalgia. When they weren't on their pain meds, they would literally take a feather in the study and they would rub it on the hand. And the person described it as if a blowtorch was being taken to their skin. So they've been so much pain meds, their life is consumed by this idea of pain. They're focused on their pain. It leads to the reinforcement of these neural pathways. So they actually are in pain. So now we're dealing with all of these addicts who've been cut off from their pain med. So what do they switch to? They go to heroin, they go to fentanyl, and now we're at an overdose 5-6 years in of 500,000 people that have died as a result of this. Like, yeah, it's an epidemic, but those are COVID numbers right there, and this was manufactured at the behest of
and to bring it back, because unfortunately we could make whole shows about just the opioid epidemic, but back to hospitals and profits, the big pharma is not just pushing pain pills. They're pushing these primary care physicians to prescribe things like Prilosec, to prescribe things like Claritin, things that are available over the counter. They push them so that they can bill, $600 for a prescription of Prilosec rather than go to Costco and get a 3-month supply for, I don't know what Costco charges for Prilosec, maybe $30 or something,
Right.
and it's just so that they can bill.
Yep, and we can shove more and more pills in people's mouths.
Because
Pills
God
are,
forbid anybody should participate in preventative medicine or
thank
diet and
you.
exercise.
Right,
But we
pills
can't
should,
teach our patients that because we have no time
we have
because we're
no,
charting.
too busy charting, right? Pills are a tool, right? They are not a curative or answer. If you're having an acute situation, we give you pills. We should then educate our patients about how to make lifestyle changes so we can get you off the pills or titrate you down to smaller doses. And our listeners, I would urge you, jump online after this and Google top, healthcare lobbyists. Spend some time, go to their website. Guess what? Out of the 20, I did like a quick search, scrolling down. I believe it's like 15 or 16 are pharmaceutical companies. Pharmaceutical companies are not healthcare. They are a service provider. They will make our equipment for beds for people to lay in. They will give us pills and the tools to treat our patients. Why do
They will create addicts, so we have a revolving door, or not
Right.
even addicts, again, just people who want pills as a solution rather than diet and exercise to cure their hypertension or diabetes or any number of conditions that are caused by a sedentary lifestyle or not the greatest diet or a downright unhealthy diet that
Right.
could be, and nobody's perfect. Nobody's going to eat a salad every day and work out for 30 minutes in the morning and then again in the afternoon. But again, more moderation would be great. But unfortunately, Big Pharma has gotten all Americans addicted to a quick fix, which is a pill. And that's why America consumes more pharmaceuticals than most other countries combined. And
Yep.
we're only 3% of the world population, you know?
Right. Like we have to wake up as a nation. Nurses have to wake up now. Big
To
pharma,
our
the
power.
corporate structure has hijacked our healthcare system for profits. They are profiteering off of your sickness. And doctors have gone along with it. For better or worse, nurses were too busy in the trenches. And we've said, our leaders, our administration, they're good people. And before the pandemic, it seemed to be okay. Things were kind of okay. Healthcare was a little okay, but it was getting by. We're modernizing, we're doing all these cool things, we're having decent outcomes, even though statistically we're paying the most money, we're still having worse outcomes than underdeveloped nations. But the pandemic has really removed that mask. Corporate medicine does not care about you, Lydia, and to people that are listening to this, they do not care about you either when you go into these hospitals. That's why we're seeing so many nurses leaving, because the conditions have deteriorated to the point, and it's been made clear, crystal clear, that your health as a person working to care for your community is not important, because you as a nurse or you as an aide, you don't actually bring money to the system. You can't bill. You don't generate revenue. You're a negative line item on their balance sheets. So you're deprioritized. So I really think
That's our diagnosis. We have to chart it.
Yep. The diagnosis is corporate medicine, and nurses, doctors, dietitians, everyone that's working at the bedside, no one's coming for us. The admin people, corporate medicine, they blew it. That's how we got to this situation, right? We have to do something ourselves. And so for the nurses that have decided to leave, get involved in politics. Start a lobbying firm. We need a doctors and nurses lobbying organization. We need to speak to the people that are making policies. We have no voice there. Get involved in local government, state government, run for Congress. There's I think 3 nurses in the National Congress right now, and they're kind of new.
Well, the one for Michigan's an idiot, to be clear, because she doesn't support vaccines. So let's support all of them with an open heart.
And I'm not supporting any individual one. I'm just saying, if you're not going to be at the bedside or you're getting out of healthcare, you're still a nurse, you're still a doctor. Don't forget about us, because we can't leave the system the way it is. We have to change it ourselves. And it starts with political action. It starts with organizing, and it starts with fighting back against corporate medicine and this toxic culture that they've created, and has led to these atrocious work environments and poor outcomes for our patients.
Right. And if the things that we've just covered here aren't enough to wake people to the scope of the problem, now that we've done our admission and have our diagnosis, just like always on the floor, there's always going to be an incident. And we're going to get into that next week with our incident report, where we talk about the physical, mental, psychological, and sometimes sexual abuse that comes from patients. Because as we all know, healthcare workers take more violence in the workplace than anyone else. 50% of all violence in the workplace is committed against healthcare workers. And we're going to get into that next week.
Oh boy, I can't wait to get punched in the face with you next week, Lydia. It's gonna be fun.
Oh man. After getting punched in the ribs at the end of my last contract, I can hardly wait to go again.
Yeah, more of the same. Well, I just want to thank everyone for sticking with us through the diagnosis. We're super excited as this show develops and starts to take form, and that you're coming along for this journey. Our goal overall is to then start creating a place and offering you tools to get involved and start bringing about changes to your lives, to your workplace, into healthcare in general. Like I said, no one's coming for us, guys, but we can do this. Have a good evening.